Yang Chong from DNDi for his introduction speech. Over to you, Han Yang.
So good afternoon, good morning to all our friends, partners and colleagues. Welcome to the second webinar of the Hepatitis C PACT. We are pleased to have all of you from different parts of the world to join us in this webinar today. Just a bit of introduction, Hepatitis C Partnership for Control and Treatment, or we call it Hepatitis C PACT, is an initiative launched in July 2021 by DNDi, together with Medicines on Frontier, MSF, FIND, the Global Alliance for Diagnostic, and Treatment Action Group, TAC, on accelerating the access to HCV diagnostic and treatment by working with closely with high HCV disease burden country, especially from the low and middle income country in various parts of the world. So the series of webinar is designed to provide a platform for countries and community to share experiences on HCV care management for the actors, policymakers, public health officials, and also advocates to cross-learn from each other on the efforts towards eliminating hepatitis C. So I would like to also thank the World Health Organization, Western Pacific Regional Office, and also the Southeast Asia Regional Office to partner with Hep C PACT for this series of webinar. So today we are privileged to have Dr. Pauline Chan as the moderator for our webinar. So Dr. Chan is currently the acting team lead for HIV, hepatitis, STIs, and is the regional technical lead for viral hepatitis at the WHO Regional Office for Western Pacific region. She has worked in various settings in Africa, South Asia, and East Asia in diverse settings of clinical services, and also in conflict settings, advising government on public health initiatives. So passionately committed to health for all, she led the WHO technical assistance to India for their establishment, scale up and decentralization of HIV STI response, and also serve in China to accelerate the HIV STI viral hepatitis C elimination. So before we start the webinar, just like to remind everyone, this webinar will be recorded for the benefit of sharing with others. So thank you. And Dr. Pauline, the floor is yours.
Thank you very much, Han Yang, for the very nice introduction and a very kind one too. It is a pleasure to welcome all participants to this PACT webinar series. When the partnership came together, we thought that we would need a lot of discussions to communicate the work of countries and the Asian region to see how we can move the whole agenda of hepatitis elimination forward. As you know, paradigm shifts and ideas are important. And of course, learning from each other is equally important, especially focusing on overcoming barriers, having focus on solutions, and also thinking about the future. And in the midst of COVID-19, it is now more important than ever to come together, have our resolve towards and work towards hepatitis elimination. And as I say, menu of tools are there. We just have to make it happen. So without further ado, I would like to introduce the first among our speakers from the country, Dr. Hai from Vietnam. Dr. Hai is the Deputy Head of Treatment and Care in the Vietnam Authority for HIV/AIDS Control Ministry of Health. He has been instrumental in driving the leadership in Vietnam on treatment for HIV, but also now for HIV/HCV care. He has more than 10 years of experience as an epidemiologist and is an infectious disease specialist working across in all the different areas of HIV, TB, HIV, and hepatitis and resource-limited settings. And he's also a very active researcher as well. So without further ado, Dr. Hai, over to you to present your experience of Vietnam and expanding services for hepatitis C for PLHIV. Over to you. Thank you.
Thank you, Dr. Pauline. Thank you so much for very nice introduction. So I will start our presentation now. So, good afternoon, good evening, everyone. I would like to thank the organizer for inviting me for to share the result of implementing HCV's care for people living with HIV in Vietnam. So, can you see my presentation? Okay, so yeah, my presentation will have for the major component, Vietnam HIV/AIDS epidemic, the profile, implementation of HCV treatment project among people living with HIV, difficulty and challenges, and let's start. As of October 2021, estimated people living with HIV in Vietnam, there are about 230,000 people living with HIV diagnosed, more than 212,000 patients. Prevalence of anti-HCV in ART patient it ranges from 26 to 44%. You can see in the chart the people living HIV AIDS and death is continuous reducing from 2007 and 2008 till now. For about the HIV treatment, as of September 2021, more than 161,000 patients are receiving ART. Patients receive TOD account for nearly 60% of total HIV patients. Risk regimen has led drug interaction to the DIA. Among the HCV, the HIV patient TOD account for nearly 93%. About the epidemiology of hepatitis C virus in Vietnam, the country has the second highest burden of viral hepatitis in the Western Pacific region. Estimates of the Ministry of Health and WHO in 2017, nearly 1 million people living with HCV infection in Vietnam, and there more than 6.6 thousand people die from HCV-related liver disease. About the HCV prevalence in general population, anti-HCV positive is 1.8%, and HCV co-antigen positive is 1%. Serotype as mostly is 1. Account for the nearly 58%, and serotype 6 account for the nearly 24%. People living in people who inject drug anti-HCV is very high, range from 50 to 70%. For people living with HIV, some research shows that the anti-HCV positive range from the 26 to 44%. About the national action plan on viral hepatitis prevention and control for periods 2020 to 2025 had been approved by Ministry of Health, which goal reduce hepatitis virus transmission, reduce morbidity and mortality from viral hepatitis C, which started by 2025. overall, 50% of people living with hepatitis B and C virus diagnosed. 60% of people eligible for treatment are treated. 95% of HCV treatment patients had the SVR12 undetectable. In HCV HIV co-infection, Turkey shows us 70% of people living with HIV HCV are diagnosed. 80% of people living with HIV and HCV receiving treatment. About the treatment of HCV for people living with HIV, Global Fund support for the DNDi drug for HCV treatment in people living with HIV. WHO supported for the development of training material, job aid, training, and electronic tool for HCV patient monitoring, so I can see monitor online with the patient treatment. VAC coordinated and implemented the project at 32 provinces that supported by the Global Fund. Other provinces have insurance will cover, but the co-payment is still high, account for 50% of payment. This is the HCV and HIV treatment service delivery model current implementation site. We start since April 2021, setting in 29 provinces have patient now at 126 outpatient clinic. Till now, the total patient as of November 3,232 patients. You can see with three level, association, provincial level, and district level have a facility and patient. Research HCV treatment data at till the end of November 2021, total number of HCV treatment patients 3,232 patients. Number of patients complete treatment 1,545, account for the 47.8%, and number of patients on treatment now is 16787, account for the 52.2%. Patient not to follow up, account for the 1.4%, and patient die during the treatment 0.2%. Patient distribution by facility, you can see the district level account for the 76% of facility, and account for the 70% for patient at the district level. Distribution of patient by risk factor, you can see the almost HCV HIV patient as the drug user, followed by the MSM, and having family member with HCV, and we have more than 51% unknown risk factor in our patient. Distribution of patient by gender and area. You can see the almost HCV patient as a man, account for the 94%, nearly 94%, and Asia almost from the 30 to 50, account for the 88.3%. Hepatitis C treatment cascade of the total 3,232 patients, 100% have been the HCV treatment, and till now only the 47.8% has the completion of HCV treatment for 12 weeks. And the number of patients eligible for the SVR12 validate, there are 205 patients, and 99.5% of that patient had the viral test done, and 99% had undetectable viral test. So, or lesson learned and challenge about the lesson learned. HCV treatment for people living with HIV is highly accepted. Very high rate of cure, 99%. So micro elimination of hepatitis C among people living with HIV is highly feasible. About the challenges, COVID-19 outbreak, especially during social distancing, has affected the project implementation. HCV viral node only available in selected provincial hospital. Many patients have a difficulty in paying for the co-payment for viral testing. District hospital have not been reimbursed for HCV treatment through health insurance, and awareness of people living with HIV about the benefit of hepatitis treatment is still low. Some doctors have not been trained to treat hepatitis C or have a low experience in treating hepatitis C. So what about the next step? We should increase the awareness on HCV treatment for key population and for the people living with HIV. We continue the advocate for reduced patient co-payment for HCV, which no insurance revive. We will put it so increase the payment from health insurance. Advocate for health insurance to reimburse for HCV at the district hospital. Third, for the capacity building for health staff at district facilities on HCV diagnosis and treatment is very important. Improve viral load testing, especially at the completion of treatment through improvement of specimen transportation. This is my presentation. I would like to share with you and would like to have your comment and give it your experience. Thank you so much.
Thank you very much for the excellent presentation, Dr. Hai. We do have a Q&A session at the end, so please write down or put into the chat your questions, and we'll get it answered at the end of the session. So without further ado, I would like to move on to our second speaker. Our second speaker is Professor Yong. Professor Yong is a distinguished, experienced teacher and professor, and he heads the Center of Excellence in Clinical Virology in the Faculty of Medicine at the Chulalongkorn University in Bangkok, Thailand. And he comes with multiple awards since 1970s, actually, including Outstanding Researcher Award from the National Research Council, Outstanding Scientist Award, and he was the Outstanding Achievement Doctor from the Medical Council of Thailand, and also from the National Vaccine Institute in Thailand. He is one of the outstanding best teachers in the among the National University Teacher Association. Professor Yong is a leading expert in viral hepatitis, and from his hepatitis work since 1986 has contributed to the drastic reduction of hepatitis A, B, and C in Thailand. But his research also involves other viruses, including avian influenza, HPV, enteric diseases, and of course now with COVID-19. He currently serves on various committees, including immunization, hepatitis, and emerging diseases for the Center of Disease Control, and he's very extensively published. So I'm going to pass it on to Professor Yong, who will tell us a little bit on the overview of the Phetchabun Hepatitis C elimination project in Thailand. Over to you, Professor.
Thank you very much, Dr. Florin, for introducing me. First, I would like to thank the organizing committee of the DNDi and Hans. Today, we are going to talk about our experience on the Phetchabun project for elimination hepatitis C in Thailand. We set the micro elimination on hepatitis C in our country. Like you know, the World Hepatitis Summit in the year 2015, they declared the Glasgow Declaration for Elimination Viral Hepatitis by the year 2030. The WHO adopted the policy in the year 2016. The target of the elimination include reduction the new cases of hepatitis C or hepatitis B at least 90%, diagnosis chronic infection cases more than 90%, and treat the chronic infection all the diagnosed should be treated more than 80%. And the result of the test to treat will reduction related death from the infection like acute liver failure, cirrhosis, or hepatocellular carcinoma at least 65%. For hepatitis C in Thailand, we would like to show the data on hepatitis C in Thailand. You see, this is a blood donor, the new blood donor in our country from the year 1995 to the year 2018. The incidence of the hepatitis C prevalent in the new blood donor is coming down from nearly 2% to 0.4 or 0.5% after the year 2010. We did the national survey to see the prevalence of hepatitis C in our country in the year 2004 and 2014. You see the incidence of the hepatitis C infection in Thailand is decreasing from nearly 2% to 1%. The incidence of hepatitis C infection in the Thai population increased with increasing age. We calculate the hepatitis C infection in our country. If you look to this slide, you can see we estimated that the hepatitis C infection in our country is around nearly 800,000 cases. We set the program for elimination hepatitis B and hepatitis C in Thailand. We select the Phetchabun province. Phetchabun province is the lower north province of Thailand. It's about 400 kilometers north to Bangkok. In this province, we found that this province is the highest incidence of hepatocellular carcinoma in our country. You see, this province is comprised of the 10 districts, and each district, the incidence of hepatocellular carcinoma, we found that the prevalence is very high in this province. More than 5 years ago, we did the zero preference of the Phetchabun province. We select 2 districts, Lom Sak and Lom Kau district, to compare with the Khon Kaen province. Khon Kaen province is a nearby province, but Khon Kaen province is located in the northeast of Thailand. we did the study of the zero preference. We found that Phetchabun province is a very high prevalence of hepatitis C. You see from this slide, Phetchabun province is a zero positive for hepatitis C. It's about 15%. When you compare to the province in the northeast of Thailand, it's 3.6%. But the average zero prevalence of hepatitis C in our country is around 1 to 2%. This is a zero prevalence and age distribution. You see, Phetchabun province we show in the blue line is a very high prevalence after the age of 30 when you compare to Khon Kaen province and national survey in the year 2014. We found that at Phetchabun province, the prevalence of hepatitis C is more than 5 times more than the Khon Kaen province. We try to do the cohort, the different preference among the age group. We found that the high prevalence of hepatitis C increased in the age above 30 years. Like this slide, you see the cutoff at the 30 years. Or we try to convert to the birth cohort. We found that ones who were born before the year 1983, that were the high prevalence of hepatitis C. Why at that period high prevalence on hepatitis C? We found that at that time we correlate with we start the immunization in the year 1968. At that time we have the baby boomer, and in the year 1975, 1955 to 1975, at that time we during the Vietnam War, we had a lot of the IVDU at that time. In the year 1982, we had the Thai Civil War at the Phetchabun province. This is maybe the reason why the Phetchabun province is a very high prevalence of hepatitis C. We did the study on the at the Phetchabun province. We randomly select 1 in 100 population above the age of 30 years. We randomly 1 in 100. At Phetchabun province, the population above the age of 30 is around 500,000. We select the population on, for our research is 5,000 subjects. This includes the 11 districts and from the 14 health center. We did the strip test or the rapid test for anti-HCV or anti-HCV. You see, this is the method to easily to detect the anti-HCV positive. This is our activity at the Phetchabun province more than 5 years ago. After the positive for the anti-HCV by rapid test, we take the blood for all of them to repeat the anti-HCV by automate anti-HCV machine by chemiluminescent technique. You see, if we compare the strip test and the automate anti-HCV chemiluminescent test, we found that the sensitivity is around 90%. Specificity is more than 99%. The accuracy is very high. Why we try to use this method for screening? Screening by strip test first. Okay. In the year 2018, we plan to do again for the set the micro elimination for hepatitis C at Phetchabun province. We use this province for extend more province in the future. You see, we set the hepatitis C RNA qualitative center for Phetchabun province. We set the 3 center to detect the hepatitis C RNA. Just only qualitative. We do not need the viral load for the treatment of hepatitis C. One, we plan for one who positive qualitative hepatitis C diagnosed. We plan to let them for treatment. Hepatitis C genotype in Phetchabun province, we found that the high prevalence of the genotype 6 in our country at Phetchabun province, the genotype 6F is more prominent. You see, like in this graph, and the second of them, genotype 3A. We plan to do the elimination hepatitis C in at Phetchabun last year, but due to the COVID, okay, why we otherwise in this year we should be complete the planning for the treatment, but we we try to do the strip test at the community by the strip test. And after that, if the positive strip test, we take the blood and send to the center, like you see the 3 center, to qualitative hepatitis C RNA test. And if the hepatitis C RNA test positive, we plan for treatment all of them. And after treatment with the DAA's drug, we plan to use the software pan-genotypic DAA drug for treatment, and we follow the result of the treatment 3 months later, complete the treatment to see the hepatitis C clearance. This is a protocol of our plan at Phetchabun province. You see, we just enroll with the first consent by strip test, and after that we screen if the strip test positive, okay, we plan to do the hepatitis C RNA by qualitative. This, if the hepatitis B, we plan to do the fibrosis by the APRI. This is a very easy way to diagnose the fibrosis of the hepatitis. Our activity last year to screen the hepatitis C and hepatitis B in this province. You see, we start from the strip test by screening, and after that we test the hepatitis C RNA qualitative test. We screen at the moment, we screen more than 150,000, and we found that 7% positive hepatitis C. The specimen with positive strip test, we sent to test the hepatitis C RNA. We found that nearly 80% of the anti-HCV positive will positive the HCV RNA. And after that, in this figure, we plan to treatment, but our pilot, we random some sample to do the viral load. Due to the NHSO, National Health Security Office, asked us to do the viral load. We random 1,000 specimens to do the viral load. And we found that if the positive qualitative test, most of them, the viral load more than 5,000 international units per milliliter. This is the data from our test. Now we did the strip test nearly 50% of this province, and we found that you see the HCV strip test positive allow 6.5%. Those positive, we found that nearly 80% positive HCV RNA, and most of them HCV RNA viral load more than 5,000 international units per milliliter. This is the prevalence of hepatitis C among districts in the Phetchabun province. This is our plan. You see, this is our plan. We did the viral load for the NHSO to make decision to do or not to do the viral load. Our result show that we do not need to do the viral load. Most of them high viral load more than 5,000 international units per milliliter. Okay, why we plan to treat all of them with positive hepatitis C RNA? We plan to use a pan-genotypic drug, and after treatment for 3 months, we plan to repeat the HCV RNA again by qualitative test. If we cannot detect the HCV RNA, it means that the treatment is a sustained virological response. Now with treatment, some of them go on the treatment, but the very few number. This project is going on. We plan to do more, and we hope that this province will be the pilot project for extend more province for the elimination of hepatitis C in the future. Okay, we plan to use the pan-genotypic drug for the treatment. This is the NHSO try to use this one. Okay, if our objective, if we achieve our objective, we have to reduction the new infection at least 90%. We need to do the HCV infection is diagnosis more than 90% by static test, but it is very easy way. And case of hepatitis C infection are treated more than 80%. This is we have some problem due to the cost of the DAA drug or software drug. If we achieve, if we can solve this problem, we think that we can reduction the mortality rate of hepatitis C at least 65% in the year 2030. Thank you very much.
Thank you, Professor Young, for fascinating and data-rich, granular data and a very epidemiologically focused presentation. There is, I think, a lot of questions around that, and we wish you good luck for the next phase of the elimination project. Now we are all ears for the next and last speaker, Dr. Kyo Samlee. Dr. Kyo Samlee is the Senior Officer for the Communicable Disease Control Department, CDC, of the Cambodia Ministry of Health, and he's the viral hepatitis focal point in Cambodia. I have to say that I've worked very closely with Dr. Kyo and his team in Cambodia, and under his leadership, as well as the Ministry of Health of Cambodia, Cambodia has, in the last several years, developed their national action plan. They've fixed down the annual action plan and now talking about sustainable financing. They are trying out and piloting new approaches on hepatitis, including NCD hepatitis synergistic integrated projects. And of course, Dr. Kyo Samlee will today talk about the topic on in Cambodia. So it's to Cambodia HCV model, how to simplify delivery towards elimination. So Dr. Kyo Samlee, over to you. Dr. Samlee, can you unmute? We don't hear you. Thank you.
Sorry, yes. Yes, thank you so much, Dr. Pauline, and all the member here. And first of all, I would like to thank you, DNDi, that organized this meeting. In this time, we can have opportunity to share experience, and we can learn from each country that have implemented HCV elimination. So please share my screen, please, my presentation, because I issue of the technical. Yes, as Pauline mentioned earlier, so the Cambodia HCV model of Cambodia, the simplified toward elimination. So I just briefed the what we have done and what we will do in the future, and we facing to the what in the future. Next, please. So the outline of my presentation, I want to share you a little bit about the Cambodia demographic health system and hepatitis burden, implementation of program, hepatitis service, hepatitis financing, the starter need and opportunity and priority in the future. For the next, please. Yes, this Cambodia demographic, we had around 16 million people. So we have the one municipal and the 24 province, the total 25 municipal, and we had the operational district around 155, and the total around, and we include the country we similar the district and the city. So the total the 193 and 97, and for the behind the commune and the village also. So I don't read all this data. So you can see in the box. So the structure system in Cambodia, they divide three. One for the we talk about from the lower level, that means the community, and then we had the health post, health center, and referral hospital, and under cover by the operational district. And the second part is the provincial, that means had the provincial department and cover the regional training center and the provincial referral also in the each province. And the last one for the high level, that means had the national level, so that means the central in the capital in the Phnom Penh. So we had the Ministry of Health, the training, the institute, like the Faculty of the Medicine, the National Center, and the National Hospital also. So if we look at the people, the incident, maybe the most people live in the urban. So for the next, please. So this hepatitis implementation, the progress. So I let you know, we just to start from the 2018. We just initiate on the clinical working group only. So we just to start the meeting with the partner like the WHO, CHI, and MSF that work on there. So we just start the meeting and discuss, find and prepare the document to implementation of the HCV and HBV elimination. So up to the December 2019, just around 1 year ago, after we initiated of the clinical working group, we have developed the national strategy plan for the viral hepatitis from the 2024, and also national clinic guideline for the treatment HCV and HBV also. So they had the indoor in the almost the end of the 2019. And right the 2020, we developed also the tool for the ME and the training curriculum for the conduct the training as well. And unfortunately, from the 2022, the COVID pandemic, so we cannot do anything. So we try to do from the implementation and the support from the MSF up to the around maybe from the 2018, but not much the population. And right the June the 2022, we have the endorsed or AOP from the director of the CDC for the implementation. So after we try to continue to working group also, we don't have the conduct the implementation of the HCV screening yet. So up to the February, around February, March, something like that, or from the 2021, we had the Catholic fund from WHO. We tried to conduct the training and for the that we selected around the our plan. We want to start 1 year 10 OD, that means the 10 operational districts. So we try to train all of them, but unfortunately we train only 8 OD because the 2 OD we cannot do because the COVID still the pandemic. So the lower level as the provincial and the operating district, they scare of the government punch like we can. We scare the we scare the people come to meet all together, had the COVID pandemic, something like that. So we cannot do so. In the 2021, we only train around 8 OD only. That means 8 operational districts. And after that, we don't have anything. We just train, but we had the opportunity from the myself that we have the some like the DDA, some the rapid test, ODT, and we also had the candidate for the GS work. So we try to let them to conduct the screening for the HCV. So we have only the AOD, and but include among the during the from the 2018 to the 2021, MSI start some small OD already, so we include all together. So for the next, please. So for the legal document in hand, we had the TWG hepatitis that endorsed by the MOH, and we also had the national study plan and the clinical guideline for the treatment HCV, HBV, and we had AOP, we had the training curriculum that established in hand. So we will do if we had the budget. So next, please. So these are only show you the document that we have in hand, and we can do if we can. We had the budget, and now we can start quickly for the implementation of the screening and for the treatment HCV, HBV also. So the next, please. This we develop the AOP every year, but even we don't have the budget, but we try to do the AOP to show the high management to consider about the HCV, HBV screening, because we have the ambition to elimination as the goal from the 2030 also. And especially Cambodia had the name in the DDA in the essential drug list from that we have endorsed from the 2018. This like the picture on the right side. For the next, please. This I just to show you. We have the national study plan. Though I just to pick up one paragraph that show you the for the Cambodia HCV elimination. We have the strategy from the 1 to 7, and we had the vision, the goal, and the objective like in the slide. But we don't waste time. So I just to show you only this much. Okay. For the next, please. For the hepatitis service that we have done, so the next, please. Yes, we decided, as I mentioned earlier, that we have the 4 levels. That means the community, health center, referral hospital, and provincial hospital, and national hospital. So this classified by the by level. But from the low level, we will do if we have any like intervention at the community. We let the VAG and the village chief, something like that, to help us to detect to education and refer the case suspect to the health facility. To the first, they refer to the health center. If the case uncomplicated, we do at there, and screening and treatment at there. If they have the complicated the case, we refer to the referral hospital from the low to food up, something like that. Yes, this is the structure that we had the activity that we prepare for the implementing the HCV screening. So we prevent, we hear the question and the screening diagnostic and care treatment as well. So for the next. This I let you know from the previous that implemented by the MSI where we want to conduct for the one patient around the 18 minutes with the here facility. But after the MSI implemented the some site, so we get the model from the MSI, so we reduce only 5 visits only. Actually, we visit only the 4 visits. So the first visit, we when the patient come, we screen and we test and the HCV and HCV. And the second visit, if we confirm the viral load from the key expert, we treat them. And after that, we provide the term at that time, the first month. And the third visit, we refill for the second month, and the fourth visit, we refill for the last month, and that's all. So for the 5 visit, we optional if the patient, but the Cambodia, from the national strategy and from the guideline, we don't do the HBR12 because from the experience from the MSS that we had the success rate it very high, right around 97% of the cure rate. So we don't do the HCV HBR12. So this the summary that we can do by the here facility. So the first and the second visit we can separate two. If the had the uncomplicated, we let the here center do. If the patient had the complicated, we refer to the doctor at the referral hospital. For the next, please. This slide, I want to share you the intervention that we have done so far. From the, I separate two, from the first ABV. ABV, we had the vaccination. The vaccination, we provide the burst dose, and the burst dose we separate from the under 24 hours. And the 3 dose more from the 1 month and a half through the national immunization program that we have done so far. So the coverage is so high also around for the burst dose under 20 hours, around 70, 85, something like that. And for the third dose of the vaccination, around 95%, something like that. So we had the data, but we don't have time to show you. We just summarize the activity. And the second point for the infant ABV, this for the blue one, we used only the PROM study that initiated by ANOS at Dr. Olivier. Maybe he had the data to show you, because we screened from among the pregnant women that had the HBV positive, and they provide the medicine, and after that the baby we provide the oxygen IgM, something like that. So this from the study, but not the whole country, just the study only. And for the HCV intervention, as you know, MSS that start from the 2026, something like that, but not much, only the one hospital in the city, and MSI expand to the one province that we call the Bandar province, and the previous, and after that we start around 6 months ago, and we had something like the DDA, like the ODT that remain from the MSI that up to now the MSI moved from the Cambodia already, so we had some remain stop. So we try to conduct the screening at the OD that we had trained from the early of the 2021, something like that around. So the total, I will show you the number of the site that we had trained. So the rate of the treatment around 98%. So we don't do the HBR12 as the result from the MSA. So the one more point that we continue so far from the previous up to now. I don't know what the time is start, but up to now, they have still provide the service from the HCV, HBV in the Sihanouk Hospital Center in the Phnom Penh. And the last one, we also have the intervention from the UNCHAD that use the co-invitation. Around they have the 70 site of the HIV treatment site in the whole country wide. So we already done this data. I just talked with the director of the UNCHAD that what they do, the screening among the key population around the 70%. So remain the 30%. They will continue if the maybe I think maybe the next year. But we collaborate with the UNCHAD for the coefficient HCV and HBV. HIV and HCV treatment. And we also have the collaborate and to support to screening with the harm reduction. That means we had one department of the mental health and sustainable birth that they do the natural exchange, something like that. But this department just have the support from Global Fund for the C19, the M or from the I don't know the what time, but they just start in the 2021 this year only. But we don't know the result yet. And the next point we also do through for the intervention to reduce the infection of the HCV. We use collaborate with the Department of the Hospital Service. That means they have the natural science plan to talk about, to discuss, to use for the health worker at the hospital to that means we can say the IPC, that means the infection control. At the health facility to how to do the prevent for the infection of the HCV, something like that. And the last one, we also the screen through the blood bank. That means we have the in Phnom Penh, we had the in province before the patient come to donate the blood. So they test and they screen and they found they refer to the service for the treatment HCV also. And but and the blood safety and bank, they screen all for the HIV, syphilis, HBV, HCV, something like that. Yeah. So this we have done in the Cambodia so far. So for the next, I get to show you a little bit about the data that we got from the, like I told you, from the MSA, from the Center Hall, from the UNCHAD, combined all together. But I let you know from the UNCHAD, maybe from the 21, they don't have the treatment for the coefficient because I don't know clearly about the issue here. But they will continue for maybe from the supply or from the support from the global, something like that. So the data we collect up to the Q3, the 2021. So estimated for the HCV infected in Cambodia around 255,000, and the result that we had the screen up to the Q3 2021 around the 211,000 for the screening case, and we found the very much positive. That means the ODT positive around 23,000, and we tracked the case around the 21. So the data you can see the chart. So from the estimate and up to the vitamin positive around the 9%, and we track them after we very much positive. We do the viral load and we track them around from the vitamin positive to the static around the 92%. So the next, please. I want to let you know about the hepatitis financing starter and the need for the opportunity. We need fund to implement to the NSP, like the commodity training and monitoring, because if we don't have the one, we cannot do anything as up to now for the among the 12 felony that implemented by the MSF, and up to date we don't have any to support them for in the future, because we don't have the auditing, we don't have the DDA, something like that, and the credit also. So I still worry about this point, so we need the fund for the continue. Even we don't have the fund for the scaling up, we need to sustain for the OD that we have implemented. Yes, I want Dr. Pauline know about this one situation in Cambodia. For the second one, HCV limited by the 2030, we asked from the NSP, we had estimated cost around the 61 million, but we would allow for the saving around 80 million there, according to save around 0.3 per the one invested, developed this calculated by the child that estimate for our technical working group. And the third point, we need for continued technical assistance from the stakeholder, especially from the child, from WHO especially, and the technical support and the fund also. And the challenge we I want you know low interest of the traditional donor, bilateral and multilateral, and to disease-specific program. The global fund support, but only the HCV. They support only the HIV, TB, malaria, etc. So this I want let you know, and the focus grow for the growing to the health system, like the health fund and fund budget, something like that. So yes, and the next for the second point is the COVID in the global, in the world. So we facing to this point also. For the next please. Yes, to continue this one, we opportunity. For the opportunity, the strong that Ministry of Health, especially Excellency Dr. Yusamat, she commitment to support the HCV program, but the government budget not yet COVID still just reduced, but not finished yet. So maybe they don't have the budget in hand to provide to the HCV program, and so but the government provide support for the supervision. So on the side for the capacity building, so at 2 months ago, I had a visit to the site to check the quality of the service at the site, and we need to stand them. If we don't go to see there, maybe we don't know the issue at the site, like the health center for reporting, something like that, and the technical of the treatment as well. So the opportunity, the third one, we possibility from the ADB fund, but Dr. Lisawan, he said that he will discuss with the ADB for the fund, some fund to support the HCV, but I don't know when. And the next point, the hepatitis was include the priority HSP4, but I just got information from the Dr. Liswan also, but I didn't see the real have they put or not, but we try to discuss with the child and with Dr. Rupa to talk about the line budget for the HSP4, but we don't have the cost yet. And the next one, as you know, we had the legal document and NSP and the guideline also indoor. So that means we can do if we had the budget for implementing. and the drug list for the DA, we had the inside the essential drug list, so we can, if we had a budget, we can do. And for the partner support so far, so as you know, the MSS project up to now they moved from the Cambodia already. So, and the MSA project they provide the service free HCV testing and treated. So this encourage the people come to the test and screen. And because when the patient move to the private clinic, maybe the charge so high, but unfortunately the MSS phase out from the Cambodia. So I don't know how we can continue or sustainable of the OD that I implemented something like that. So from me, I want to have some budget like to support to sustain among the OD that we have implemented something like that, and also the CHAI still support from the ME and IC training something like that, and this very important. If we don't have the partner to support the HCV or ABB program, maybe we will fail down. Okay, for the next please. So a way forward, we had the resource mobilization from the government, donor, stakeholder, and if we had that one, like I mentioned, we can run quickly, and we plan to train around the 10 OD more in the 2022, but we don't know how we have the budget on that. Okay, the next point for the strengthening existing and the continue of the HCV service in the 12 OD that we have done from the 2021. And if we had the budget, we scale up if possible, if we had. And the shape of the national program for the next year and 22, 23, Cambodia had the election. So if we let the charge some, the co-share, the pay from the patient, maybe we don't know yet. So we try to discuss with the partner like the CHAI, MSI. Oh, sorry. Yeah, MSI, Dr. Mikael still discuss with us every meeting. So from the 2 days ago, we talked with myself. So my will support us, and clinical also budget, I don't know, but he still joined the TWG, and yes, but from the out of pocket payment from the patient, maybe the Cambodia hard to do because the people still poor. Even we don't charge the budget, the people don't understand, they don't come also, and the last one, the last point, if we had the budget, we had the continue to our team with the 1 point for the encourage the people to screen, because we need to do awareness like the Vietnam mentioned, because the people don't understand yet, because the people don't care, because they care about how to find the money to live only. So yes, from my president, that means all. But I want to show you some activity that we have done so far. For the next, please. Next, please. Yes, we had the meeting to dissemination workshop to discuss, to finalize the national guideline, national NSP. We had the try to meeting with the partner and endorsed by the MOA. So for the next, please, one more slide. This we do even the one slide, even the COVID, we start to conduct the meeting, we use the malware and discuss all together, something like that. Just for the next one. Next one, please. Yes, yes, one more. Move back a little bit. Move back. Yes, these people. You see, the many people come to screen. This conducted by the hotspot in the Kosa province. I joined this one, so I take the picture. So the people come, but if they know about our activity, the screen, the treatment, they come to join. But up to now we cannot do because this we do from the 2019 before the COVID pandemic. But some part they had from the 2020, and the top one they do from the 2029. So all my presentation, thank you so much for your inviting to share the HCV modeling out in Cambodia. Thank you, Pauline, and our team. Over to you.
Thank you, Dr. Samli. And you can see that Cambodia has done it very systematically to pave the way of program towards hepatitis elimination. It's challenging. Sustainable financing is all in our minds because that's the way to get towards financing towards elimination. But Cambodia has and is still making the case to invest and to advocate for financing for hepatitis elimination. This is something that all of us will continue to lead to do, also amidst the COVID-19 pandemic. There are an exciting number of, a lot of actually questions for the panel. So I'll start with Dr. Hai. So what is the Vietnam, or how is Vietnam managing patients who do not respond to first-line hepatitis C treatment?
Thank you, Dr. Pauline Chan. I think that if the patient do not respond to first-line treatment, we have to refer them to the higher level for HCV and treatment. They had been if they are on the treatment at the district level, they have to refer to the provincial level or the central level. At that hospital, we have a specialist on the HCV treatment, and the patient have to do the serotype, and also we have the consultation on that case, so that we have to choose a suitable regimen and timeline for the treatment, 12 or 24 weeks, and the suitable regimen. We have software to follow the patient. If the patient has SVR 12 not undetectable, we have information about them and have refer them to the higher level for the HCV treatment. Yeah, it's my answer for your question.
Thank you very much, Dr. Hai. There is a question on how Vietnam managed to justify to Global Fund to fund the hepatitis C and PLHIV co-infection treatment in the country. But I would also like to ask Dr. Kyo Samli, because I know that Cambodia and Vietnam are the only two countries that have managed to get Global Fund funding to treat PLHIV for hepatitis C. So perhaps Dr. Hai, over to you, and Dr. Kyo for you to add in. Thank you.
Yeah, thank you, Dr. Pauline. For the HCV treatment in Vietnam, supported by Global Fund, we have software named HMED. It means HIV medicine. We in that software we have a module for the HCV HIV treatment. That's a module supported by the WHO in Vietnam for the technical, for the financing, for the developing that module. So now we can manage all the HCV, HIV patent treatment through the ID. So for me, in the central level, we can see at each facility have how many the patent on HCV treatment there, and how many the patent had affiliated 12 with the HCV treatment, and so on. So ID is a secret private information patent. We don't care, but we have see the process of treatment through the ID, and so that we can minute manage who will be the treatment, HCV treatment by the global fund donor. That software is very useful. It have a dashboard and all the information I share with you today. I take very easy from that software. Thank you.
Thank you, Dr. Hai. Dr. Kyo Sabri, how did Cambodia advocate to Global Fund to use Global Fund funding to support DAA treatment for PLHIV? Oh, you're on mute. Please unmute. Please unmute. Thank you.
Okay. Yes. Thank you, Dr. Pauline. Actually, your question maybe you asked the answer maybe correct than me, but I just to know from this morning because I meet some colleagues from the ANCHAT. They have to the meeting for the review of the achievement global fund from the HIV and the TB grant. So actually they have done so far, but for the target, the key population, they already tried around the 70%. So they use the global fund, they had the TAC, and they had the DDA, and also they had the screening with the key population. So remain around the 30 from the estimated of the key population, the HIV. So maybe this year, maybe the next year, sorry, we for the 2022, they will continue to screen and screen also the new case infection of the HIV. So maybe they had a fund to support to continue from the coefficient HCV and HIV. I think I know only this much. Sorry.
Yeah, I could like to clarify and give you some information when we when we have supported from Global Fund. We have very happy with the supported from WHO in Vietnam. So WHO in Vietnam have support us in the making the case for the HCV treatment in Vietnam, including the burden estimation and cost analysis. So from that, the information and data and advocacy during the Global Fund visit Vietnam and through the telephone and so on. So Global Fund has support us for the HCV HIV treatment in Vietnam. And now maybe the expand for MNT patent in the 2022 too. Thank you.
For the Cambodia, Pauline, I just to tell you the program is for today and tomorrow we will discuss much about the HIV and TB using the global fund budget for the next year. So I know about the situation of the Cambodia but this morning the director of the ANCHAT he told me they have the target around for the 8 people around 60,000, but now they track them around 50 50,000. So remain around 10,000, like the 12,000, something like that. So maybe they will find them and to track HIV include the screening HCV also. But maybe the next year. Yes, over to you.
Thank you very much, Dr. Kyo and Dr. Hai. The main message to the audience of this webinar is this: Global Fund does provide funding for DAA and treatment and testing for PL-HIV, because this is part of PL-HIV care. So the main thing is that your CCM is important to push the case and to advocate to Global Fund for funding this area, whether it's in new grants or is in reprogramming of your Global Fund country grants. So this is quite an important thing, is to realize that it is possible. It is possible, and it has to be asked and requested for.
Yes, but from me, Dr. Pauline, if WHO can push the Global Fund to support the HCV program, I think it's better than, because actually the HCV infection may be the higher than the HIV up to now, because I just came from the visit at the site. I calculate maybe the some side among the people testing and the screening of the among the people that come to the audited test and they got the positive audit and got the from the positive audit to the wild load positive, maybe the around the 10%, around the 16, something like that, some side around 10%. So maybe it very high. Yes. So
Yes.
either compared to the HIV, maybe the small, but this for the HCV disease, that means the people they don't know before or they don't care because it's a long time ago that they say the natural of the infection, something like that. I think so. They don't know. Yes. So if we have the Global Fund support, we try to, for the education, use the channel, the awareness, and for using the VAHG, that means Village Health Support Group, to educate the people. Maybe we can eliminate by the 2030. Yes, thank you. Over.
Thank you, Dr. Kyo. Precisely this, Global Fund will probably not be funding hepatitis C directly, but there are opportunities to explore integrated services. And this is really the message, is that work through the integration and health system strengthening so that you can tap into the Global Fund funds that can provide for elimination of mother-to-child transmission, for PL-HIV micro-elimination, and that could actually change the conversation in the country as well. Now I'm going to ask Professor Yong, there's a question for you that from your experience in the Pechabun project, what are some of the elements you feel that Thailand or other countries can learn from to upscale the hepatitis C treatment services towards elimination? From your perspective. Thank you.
Yes, if we plan to elimination for the whole country, we have to set the pilot project like a micro elimination first, and after that we plan to extend more and more provinces. From our experience to do in this job, we think the problem on the treatment, the problem on the treatment cost. The treatment cost is very important because due to the budget of the government, this is a big problem for us. If we can, if we can find like a DAA, generic DAA drug for like the cheap cost, it may be possible for elimination.
So basically, we still have the issue where we have actually the menu of tools already. The drugs are there, the test kits are there, but affordability continues to be an issue. And there is no magic bullet to affordability. You have to work through health systems, plus also the focused approach from the disease elimination side. And having an elimination plan actually helps in articulating the national vision towards elimination so that suppliers and manufacturers can also bring down the pricing through bulk procurement. That's some of the experience and the messaging that we have seen across the region and also from other webinars as well. My question to maybe to all the speakers is this, and this is also a question from the audience, you know, what is the strategy for finding the missing millions of hepatitis C now? Because PLA-HIV is a small group. In most countries, the epidemic is the general population, not only those who are ever injected. Because there are more millions or more hundreds thousands that are from general population, but they are not the key population or HIV key populations themselves. So what's your take on it? Maybe Professor Yong,
Yes,
over
yes.
to you.
Okay, for our experience, I think like in our country, IVDU at the moment is not the big problem, because you know, the incidence of IVDU now is very decreasing. We have the ingest drug more than the IVDU. Like you know, if you look to the incidence of the hepatitis C in some area, many of them not the IVDU. In the general population, we have to take care of them, not only HIV or inject IVDU, because in general population it's very important, because it's very productive person. For me, I think we have to take care for all of them, not only some special group.
So how about you, Dr. Hai and Dr. Samli? Because the epidemic in Vietnam is beyond people who inject drugs.
Yeah, I think the HCV in Vietnam is almost focused on some key population such as ITU and it's so we for the effectively we should focus on some of the key population first. Yeah. And we should screen and treat them sooner, so we can interrupt the transmission of that virus. Yeah. Thank you.
Dr. Samli, what's your take on it? Hepatitis C testing strategies.
Yes, I think we should do the both in coefficient HIV, include the general population. If we do the one side only, like Dr. Pauline mentioned, we can do small for the key population of the HIV, but the general population is the truth. So they can be, if the one people infected in the family, they can continue spread to the member. So we can do the all, not the focus on the key population like HIV. So like the Cambodia around 60,000 only people, but the Cambodia had 16 million people. So if we compare the number of the key population to the general population, maybe it's still different. So should be considered all for especially the poor people, general population, so we can reach all, and it's sweet for the old people around from the 45 years old, maybe the infected of the HCV, and in the future. So I think we should consider all, and we do all together. Yes, from my over.
Thank you very much. It seems that we need to prioritize, but yet also ensure that there's some routine services for the general population, because we have to be reminded that hepatitis C is transmitted through mother-to-child transmission, unsafe injections, unscreened blood products in the past, unsterile needles, unsterile dental care. So there is a broad range of transmission routes aside from injecting drug use. And it's a very challenging discussion indeed, how to you prioritize resource when your resources are limited. I have also one more question to Professor Yong. Professor Yong, there is a question on the because Thailand is seeing genotype hepatitis C for 1, 2, and 6. So how do you use DAA for this kind of genotypes that are so variable in Thailand?
Yes, in Thailand, the genotype, we have done a lot in different geographic country, like in the north and northeast. The genotype, like I showed to you, the genotype 6 and genotype 3 and genotype 1. Okay, for my idea for the treatment, we we can skip the genotype screening if we can use the pan-genotypic drug. If we can use a pan-genotypic drug, we can save the money for genotyping. And this the cost of the genotyping. We can use this is the cost for the drug treatment. If you use a pan-genotypic drug, no need for doing the genotype.
Absolutely, Professor Young. Pan-genotypic regimens remove the cost of genotyping, which is usually many hundreds of dollars. And the other thing is this screening test for hepatitis C is now under $1 per test.
Yes.
Gene Expert is only Gene Expert cartridge for hepatitis C and hepatitis B is only around $15 per test. And
yes.
if you say that we want to have lower cost for confirmation of hepatitis C core antigen serology, if your machine does it, is only between $5 to $8 per test. So
yes,
there are possibilities to reduce the cost of testing.
Okay, I would like to comment on this point. You know, if you use a qualitative test by the automated machine, like I do, okay, the cost of the the stick test is less than $1. I agree, and the qualitative RT-PCR it costs about $10 to $15. Not expensive, and you can do more than Gene Experts. Gene Expert, you can if you have a lot of people patients to do it's very slow because it like the panel you can do just only 4 or 8 specimen. Okay, but for my idea we can set like the node or the area for do the qualitative PCR. This is a very fast to do. For my idea, we plan to do at Phetchabun province, we set just only 3 machines for qualitative RT-PCR. We can handle a lot of samples per day, and the cost is expensive.
So technically, it's possible to batch test a very big batch of samples, and also push the cost down.
Yes, the cost is the same like a Gene Expert.
Right. So technology as well. We have to be sure about what kind of technology exists in the countries.
I am sure the technology is okay because the COVID drive at. If you can diagnose COVID by RT-PCR, you can diagnose hepatitis C PCR as well.
Exactly. Therefore, during COVID-19, many governments invested in a lot of technology, and this could be leveraged for hepatitis elimination. We are finishing and we are top of the hour for the webinar. I would like to say that it's been fascinating to hear from the 3 speakers, and please join me in thanking all the speakers for really in-depth, rich country experience. And the breadth of the discussions today has been extensive. We range from the concepts of micro-elimination and how to you prioritize and get value for money to eliminate hepatitis C, to a strong message that decentralization is feasible, is cheaper, and you can do integrated models to deliver at districts and below, because hepatitis C DAA treatment is just so effective.
Yeah.
Anybody can deliver it, basically.
Yeah.
And lastly, while we, in many countries where there's a lot of active discussions on elimination, but the financing part hasn't come across, it is still important to make the case about investments, but also to ensure that all the systems things are also incorporated, ensuring drugs are in the essential medicine list, healthcare workers are trained, do public communications for general
Yeah.
awareness, and
Yeah.
make drugs and test kits affordable.
Yes.
And lastly, while we didn't touch upon it, stigma discrimination is a barrier, as we know from HIV program, and whether it's B, hepatitis B or hepatitis C. So stigma discrimination is not only an external manifestation, but also internal to patients as well. And we need to ensure that we hear from communities to try to reach out to them and get them into services. So thank you very much all. And with this, I think we can close the webinar.
Yes, thank you so much, Pauline.
Thank you, Bob. Thank you very much.
Thank you so much,
See you.
Pauline.
Please,
Thank you.
Cambodia. Okay.
Okay, bye bye.
Bye bye.
Thank
See
you.
you.
Bye-bye.
See you
Bye.
next time. Okay.
Bye.